Okay, you can discuss this later, you can fix your computer later. So I start describing this case. It's a 45-year-old woman presents to the emergency department 2 days after thyroid surgery with numbness, fingertips and painful muscle cramps in both hands. She reports feeling anxious and says her hands tighten suddenly. On examination, inflation of the blood pressure cuff causes carpopedal spasm of the hand. Have you covered this before, calcium, by any means, physiology or cell biology? So this is basically, if you look at the lab, this is what it has. Serum is low, the total serum and calcium is low, ionized calcium is low, and then the PTH was the main thing here is also low. This is a typical case of the removal of the parathyroid gland, and usually happen accidentally many times when you remove the thyroid gland. So we'll go through the lecture and we'll explain why this happened. This will be basically describing how calcium is controlled by PTH, as we'll see. So to understand this case, we should answer the question why calcium must be tightly controlled, how parathyroid gland senses calcium, and how the PTH act on both bone and kidney to restore calcium. So in the histology lecture, I show you the functions of the bone. I said mechanical structures, but the main thing is also storage of elements and then act as a reservoir for calcium. This is the main mineral that actually gets stored in the skeleton. And the concentration in the extracellular, as we'll see, is very, very sensitive to changes. So this lecture and the coming couple of lectures will be basically talking about how calcium is regulated by many hormones. So when you look at the total body calcium distribution, we have about 1 kilogram, 1,000 grams of calcium. 99% of that is inside your skeleton in the form of those hydroxyapatite. We said in the mineral we have organic and inorganic component. Organic component is type 1 collagen, the inorganic component is the hydroxyapatite. Hydroxyapatite is actually calcium and phosphate, mostly calcium. So all your calcium, 99% of your calcium is stored inside the skeleton. Only 1% of this, which is 10 grams only, located in the blood, in the extracellular fluid, and inside your soft tissues. The 1% is also divided into one-tenth of the 1%, which is 1 over 1,000, which is basically 1 gram, is existing in the extracellular fluid, but the other 90% of the 1%, which is 0.9%, sits in the cellular organelles inside the cell. So it's only 1 over 1,000 of your calcium is actually existing in the extracellular fluid, including your blood as well. So even in the extracellular compartment, which is the 1 over 1,000, exists in two forms mostly: the free ionized calcium, which is the active form. This is all what we worry about, actually, the free ionized calcium, which is half of the 1 over 1,000. So half of the 0.1%. So it's very, very small. So we're talking about the total is about 1 gram, then about 1/10 of that. So we're talking about 100 milligram only. Yes, actually activated. So you can see the ionized calcium exists in two forms. The ionized calcium is only 50% of the extracellular, and some of those which is bound to protein. The ionized, which is the free calcium, is doing all the function. Everything else is stored. These numbers are important to understand. It's just showing you how small the calcium in the blood is, the active calcium. That's why the sensitivity and the reading of the calcium when you read somebody's lab, the range is very tight, and any changes can make significant clinical effect. So that's why in the control of the calcium in the bone is very important. And calcium is available to the body only through the dietary intake. We don't make calcium inside the body. So why this is important? Because the calcium is really critical for neural transmission, muscle contraction, membrane stability. So in the case of the lady that we discussed earlier in the case, she had low calcium because of the gland was removed, the parathyroid. So she ends up with this sensitivity of the nerve. That's why she got this tingling and numbness and even the contraction. There's a specific test if somebody have this kind of symptom. If you put the cuff, a sphygmomanometer, and then you raise the the pressure, because you cut the blood a little bit, you start having spasm in the hand. Now, this regulation rely, that we'll be talking about the next couple of lectures, on three main factors. The parathyroid hormone, the PTH, which is coming from the parathyroid gland, vitamin D that comes from the diet, and another hormone is called calcitonin that's secreted by the thyroid gland. We'll be discussing all these three. And those three factors will target three organs: the intestine, the kidney, and the bone. So over the next couple of lectures, we'll look at the regulation of calcium through the parathyroid hormone, the vitamin D, and calcitonin, and how they affect the intestine, the kidney, and the bone. So these are a list of factors that also regulate calcium, but we'll focus only on the three. If I have time, I might talk a little bit about the sixth steroid and the other hormones, but they are not as major player, but you have some effects on the bone as well. Just in case if you read something and you said, oh, it's not only those factors, yes, I know, but for the sake of time and not to make things complicated, we'll just focus on the main three. So the parathyroid gland, I know you did not cover that in the histology or endocrinology. So these are very small glands that sits in the posterior surface of the thyroid. You took the thyroid, I'm sure. So I have two lobes. In each lobe of the back surface, you have two glands, one superior and one inferior. So I have one right and left, upper and lower. They're really small. We're talking about 4 by 4 or 5 by 5 in diameter, and about 1 to 2 millimeter in thick. So lentiform is the size of the lenti grain. So very small, 30 to 40 milligram. Stromal adipose tissue exists. It has a capsule which extended into septa. Even it's very small, but still, it's a capsulated gland. It has septum and has some fat inside. So the stroma can be actually, the older you get more fat deposited inside. As you can see in this section here, you see a lot of fat infiltrating. And you can see just higher magnification, and it's very vascular. Again, this is a endocrine or exocrine gland. Endocrine gland, there's no ducts. I mean, with this size, you don't expect ducts. So you can see a lot of capillaries next to all these glands. So it's very, very effective, very, very important when it comes to body function. And you have two types of cells. The first one is called chief cells. These are the ones that making the parathyroid hormone that we'll be talking about, controlling the calcium. These are the more numerous cells. They are actually slightly eosinophilic. They are rounded. They are small, about 6 to 8 micron in diameter. They make anastomosing sometimes like that, cords with very delicate connective tissue between them. You'll see that in the lab as well. Again, very extensive capillary network. Some of the cells, sometimes they look clear. Like these are the same cells. The chief cells are here, both of these. These are the better one, but some of those, they contain some glycogen in the cytoplasm, and that's why they have a clearer area surrounding the nuclei. The other type of cells is called the oxyphil cells. They are actually more eosinophilic. These are the bigger one, much bigger, 12 to 20 micron. Larger, number increases with age, irregularly distributed. The function is not really clear. But anyway, so how is calcium regulated? So we have something called calcium sensing receptors that tell us the level of ionized calcium in the blood. So that's distributed on multiple organs. They exist on the parathyroid gland, the chief cells. They also exist in the kidney and on the osteoclast on the bone surface. So we have something called calcium sensing receptors. These are receptors that need agonist or ligand, which is the ionized calcium. So the ionized calcium will be circulating in the blood, and you will be sensed by those calcium sensing receptors that tell us how much calcium you have in the body. This is the structure of those calcium sensing receptors. These are family of the G protein coupled receptors. You know about those or no?
Yes.
Yeah, okay. I told you that. Again, expressed in the parathyroid gland and kidneys, and also a little bit in the osteoclast. They affect how the calcium homeostasis, because this will tell us how much calcium we have in the body. We also have the parathyroid hormone, which is secreted by the parathyroid gland. So the calcium sensing receptors exist on the parathyroid gland, will also detect the ionized calcium. So as long as we have enough calcium in the circulation, enough ionized calcium in circulation, these calcium sensing receptors, especially the one on the parathyroid gland, on the chief cells, will feel, oh, we have enough calcium, so nothing's going to happen. So this is just another illustration showing you the mechanism of action. So this again, this is the chief cells in the parathyroid. Ionized calcium circulating. These are the calcium sensing receptors, the G-protein coupled receptors. As long as we have enough calcium, the calcium will keep filling all these receptors, calcium sensing receptors. So nothing happened to the receptor, but it will actually stimulate this signaling mechanism through the phospholipase A, which causes degradation of PTH. So the parathyroid gland always, this is their function, the chief cells, they always make parathyroid hormone. But as long as we have enough calcium, we don't need the parathyroid hormone. So what happens is, enough calcium will fill all the receptors will send this signal all the time inside the cell. Any PTH is made, break it down to be degraded. When we don't have enough ionized calcium, many of those receptors will be free, will be open. There is conformational change, the receptor will change because it doesn't have to bind it. And then what happens is the degradation will stop. It doesn't stimulate through the signaling, breaking down or degrading the PTH is going to be released. You release the brake. Now the PTH that's made will stay. It's not going to be degraded. So it's going to be released outside the cell. So a slight decrease in this ionized calcium will make these changes, and then the calcium will be, the PTH will be released inside the circulation. The function, again, the function of the parathyroid gland, the chief cells, is to make the parathyroid hormone, PTH. They do that all the time. But if we have enough calcium in the circulation, ionized calcium, it's not going to be released. Why? Because the calcium in the circulation will bind to the receptor, those receptors will send signaling, break all this PTH. We don't have enough ionized calcium. This will be empty receptors. The empty receptors will actually, there's no signaling now mechanism to break down or degrade the PTH. So the PTH will be accumulated in the cell and then will be released. So what will happen when the PTH is released? It will go to the circulation. It will hit many targets. The first one is going to be in the bone. So PTH is going to be released in the circulation, and PTH works through PTH receptor, PTH1 receptor. PTH1 receptor exists on the bone, as we'll see. Also in the kidney, but we'll talk about the bone now. There's two targets here, you can see the bone and the kidney. So first we'll be talking about the initiation of remodeling. This is something that little bit, I didn't explain much in the histology because it will fit better actually here. So we said we have a remodeling process that happens both in the cortical and trabecular bone. And we said this is actually a coupling process, resorption and formation. So osteoclast will come and resorb the bone followed by the osteoblast. And we said that why we do this remodeling process. Anybody remember why we remodel the bone? Why we remove all the bone and replace it with a new one? Two main things.
For strength?
Yeah, for strength, microfracture, something else.
And release of calcium?
Yeah, often all these are based on the microfracture, something else.
Release of calcium?
Yeah, exactly. The other thing is calcium homeostasis. If we get a trigger, because what is the calcium? I said 99% of the calcium is stored in the bone. So if you have a problem with the calcium, the first thing is going to be actually releasing the calcium from the bone. So we will trigger this remodeling process. So I'm just going to go into some details here with the remodeling process. Yeah, remember this is the bone surface here. And we said we always have a lining cell, which is an inactive osteoblast covering the surface. So when you get a signal that we need to remodel this area, this very selected area in the bone is going to be the remodeling process happening. So it's called the initiation of remodeling, which is in this case the lining cells are left, as you can see, and they form what we call canopy. They are separated from the surface. This is supposed to be a flat surface here. But then those osteoblasts, the lining cells, will get elevated and they actually close the sealant area or define an area. It's called the canopy. This will define the area where the remodeling process is going to happen because other surfaces will be quiescent. Nothing's going to happen. This one will be creating and protecting this environment for recruitment of osteoclasts, because osteoclasts will come first. So osteoblasts remove themselves from the area because we need to have this surface free so the osteoclasts can come. So osteoclasts will come and then resorb this area of bone, as we see here, the red ones, the multinucleated cells. And the osteoblasts will come, of course, and fill after that. But what's exactly the signaling mechanism that tells those cells to work together? This through the rank ligand OPG pathway. So rank ligand is a long name. It's a receptor activator of nuclear factor kappa B beta ligand, but we call it rank ligand. Member of this human growth factor expressed on osteoblasts and other marrow cells. And rank, which is also from the TNF family, is expressed on the macrophagous monocyte, which is basically the osteoclast and its precursor. So this is just how they look like. These are transmembrane domain, and you have extracellular and intracellular, both of these. So the ligand is the molecule that binds to the receptor, which is the rank. So rank ligand will be expressed by cells, osteoblast. The rank is the receptor that will be expressed by the osteoclast and osteoclast precursors. Also protogerin, OPG, some people pronounce it osteoprotegerin, function as what we call decoy receptor. This actually acts as a receptor as if they are rank receptor. So to receive the rank ligand in a manner that we discuss. So how is the remodeling happen? Now we get a signal that the osteoclast need to break the bone. So it's actually the osteoblast is the one that will be releasing the ligand, the receptor, the signal, to the osteoclast to then resorb the bone. So the osteoblast, which is the bone-forming cells, are the cells that tell the osteoclast, please resorb the bone because we need to rebuild it back. So, and this is the mechanism, or the signaling mechanism, is through the rank ligand. Osteoblast will release the rank ligand, rank L, and this will go and bind to the rank receptor on top of the osteoclast. Once this happens, the osteoclast will be activated. See, and then we have also the released osteoprotegerin. Osteoprotegerin is actually a decoy receptor, because as long as osteoblasts are sending all this rank ligand, the osteoclast will keep activating. So in order to stop this, you start releasing osteoprotegerin. Osteoprotegerin is the decoy. Rank ligand think this is a rank receptor, that's an osteoclast, and they bind to it. And so the signal is not going to go to the osteoclast, so the osteoclast will stop working. It's a little bit complicated. I hope this will be. So the osteoblast, so the remodeling happened like this. A signal is going to come, tell that this area has to be remodeled for many reasons. First thing, the lining cell will be elevated and making the canopy. And then the osteoblast will start sending signals to the osteoclast, come here and resolve the bone. The signaling is through the rank ligand and OPG. Osteoblast will send rank ligand. Ligand will be released. It needs a receptor. The receptor exists on the surface of the osteoclast or pre-osteoclast, the monocyte. They make more osteoclast and also activate all existing osteoclast. So once the ligand binds to the receptor, the osteoclast will be activated, resolving the bone. And then to stop this, the osteoblast will release what we call osteoprotegerin. Osteoprotegerin is decoy, because they cannot stop anything, because they also release the ligand. So the ligand is going to stay in the extracellular fluid for some time. So they release all this decoy receptor. Decoy means fake. So it means that all those rank ligand will bind to those decoy receptors, and instead of binding to the actual receptor in the osteoclast, so the osteoclast doesn't get any signal, they don't work, then stop. Then it will be the end of the remodeling process. Is that clear?
Yes.
Okay. To make things a little bit complicated, we said the osteoblast send the signal to the osteoclast. Also the osteoclast send signaling to the osteoblast to build. So the express, again, osteoclast will express. Rank ligand is the main one that we studied, and it's actually the main mechanism, but there are other things like MEC, NCF, Wnt5, and so on. But osteoclast also send signaling such as the MMPs, the BMPs, and Wnt and other SMAD-A4. All this will tell the osteoblast now we're finished. Come and rebuild the bone. So that's why I said before it's a coupling process, and that's why always in histological section you see them next to each other. Because they don't, I mean, it's not much time. Once the resorbing is done, the signaling osteoblasts will come in. So it means actually it's not everybody of these cell types work independently, but they rather work together. Both of these work together to finish the mechanism of the bone removal. So how the PTH affect on the bone? So we revise this. We have low calcium. So when low calcium is not binding to the receptor, or as long as calcium is binding to the calcium sensing receptor on the thyroid gland, it will cause degradation of the parathyroid hormone. So if we don't have enough calcium, ionized calcium, by not auto the calcium, usually ionized calcium is what we're talking about. We don't have enough. This conformational change, this receptor will be different, so it's not going to trigger the signal that was breaking the PTH. So the PTH is going to be released. PTH is going to go into circulation because this endocrine gland, PTH will try to find the receptors. Correct?
Yes.
They bind on the receptors which are existing, we said, on the osteoblast and also on the osteocytes. Correct?
Yes.
Yes. And once this happens, the osteoblast and osteoclast will release the rank ligand. And then rank ligand will bind to the rank receptor on top of the osteoclast. So the osteoclast will be activated. So what will happen? Osteoclast will resorb the bone, break the bone. What will happen?
Send signal to
Will release the
osteoblasts.
calcium. Yes. So the calcium will go back in the circulation, and then will go back inside the circulation, bind to the receptor, calcium sensing receptors, and start degrading the PTH again. So stop making. So until you make enough calcium in the circulation, that's why it's very tight. It happens quickly. Because, again, the range is very small, but also the mechanism is quick. So this is a response that the body do with the PTH. That's why when we talk about this patient in the beginning, that she removed this gland. She doesn't do, any breakdown of the bone. So she had hypocalcemia because she doesn't have a PTH to break the bone. So that's actually, you can go into emergency because of this. Yes, do the actually accidentally remove? Yes. If you see how small this is, as I said, it's 4 by 4 millimeters. It's tiny. And thyroid gland is much bigger, especially somebody who have a large thyroid. A lot of surgeons, they can't remove, or they can't see. It's also very difficult to identify. So how do you think they manage this? They have also not only that, sometimes they call it avascular necrosis. They cut the blood vessel, the parathyroid arc inferior or something, and then end up the cells will die again. Cell will die. So most of them, they even leave a little bit of the thyroid tissue in place, or they actually reimplant it. They take it and they put it in the sternocleidomastoid. They insert it inside the muscle, and they will get the blood supply, because otherwise a problem. So they usually do that when they remove the thyroid, if it's something that you need to. So I did just summarize what I said now. Anybody can summarize this. It's not difficult. I put a lot of slides, but simple. You have to understand this. The question is going to be about the mechanism. Anybody can tell me the story. Yeah, go ahead. Do you need the microphone? Or can you hear me? Tell me about the calcium. How calcium level is controlled. It's not difficult, but you have to remember how this all linked. And make sure that it's clear in your mind. Go ahead.
Ionized calcium bind to the G protein couple receptors.
What is that receptor called?
Calcium sensor receptors.
Yes, exactly. It's very simple. It's a receptor that sense calcium. Yeah, we just make it complicated when we say G protein. Go ahead.
It does conformational changes, which would lead to continuous degradation of the parathyroid hormone.
Yes.
And the parathyroid hormone, if there's low levels of calcium, the G protein couple receptor, the calcium sensor receptors would stop the degradation of the parathyroid hormone.
But the conformation happens actually when there's no calcium. Yeah, but correct.
So when parathyroid hormone is then released to the blood, it would go to the osteocytes and osteoblasts and bind to them. And when
Through what? The PTH binds to what? PTH1 receptor. Yes. The receptor for
the
the PTH.
PTH1 receptors, and then it was released RECKL, the hormone,
Ligand, rank ligand.
rank ligand. Rank ligand, with them, when it's released with the osteocyte and osteoblast, it would go bind to the osteoclast. Rank is when it bind to them, they would start the degradation. But the osteocytes, they release osteoprogenitor hormone.
Both osteocytes and osteoblasts.
Osteoblasts and osteocyte, they both release the osteoprogenitor hormone, which is
Osteoprogenitor, yeah. Whatever.
which is kind of like a fake hormone in place of the rank ligand, which
No, it's a fake receptor.
specific receptor.
Yeah, so they secrete both the ligand and the OPG. Yeah, so it is a decoy receptor.
So a decoy receptor, and that would stop the osteoclast from breaking down.
Yeah, because it will occupy the ligand will bind to them instead of the actual receptor. So the osteoclast will be active and then resolve the bond, get some relief. Excellent, thank you. Did you study this before? Just pick it up. Yes, there's actually, it's a quick balance. So it depends if actually they want to really to stop it now, they actually decrease the release of OPG. If they need to stop the process, they stop. So the balance is important. Yes, I mean, PTH is one, but many other things are controlling the healing processes. It's not all of PTH causing this flow. For the calcium, it is. Yeah, because if you have a microfracture, it's not really based on the PTH. PTH is only in response to the calcium homeostasis. Very good, so I'm happy that it's clear. I hope it's clear to everybody else the same. Okay. So now, a few minutes on how the osteoclast to resolve the bone. We said the osteoclast will sit on the surface to break down the matrix of the bone, which contain both mineralized matrix, which is the hydroxyapatite, as well as the organic. First, they will be breaking down the mineralized matrix, the hydroxyapatite, and then we'll break down the organic component of the bone matrix. So the osteoclast will have two main things actually, which is that cause the resorption. They form this lacunae, which they seal, and also they have the ruffled border. We said the border that's facing the osteoclast border, that's facing the bone, will be ruffled, have all these membrane foldings, increasing the surface area. And they seal the area. These are the two main mechanisms by which this resorptive machinery will start. So the sealing zone is happening through the binding of this alpha V beta 3 integrin. You remember the integrin is one of the adhesion molecule we talked about earlier in the epithelium. To the vitronectin, which is on the bone surface. So they tight, it's like they lock themselves inside the area where they're going to be, as I said before, when you go to the working zone, they usually close the area and seal it so nobody will come in. This is important because none of the contents should be released outside the area, otherwise things will be spilling outside. So the ruffled border is the border that will be carrying all this, the protons and proteolytic enzymes to break down the matrix and dissolve it. So inside the osteoclast, which you can, I don't know if you can see on the surface, but you can see the ruffled border here facing. So what's this groove here is called? Lacunae. Yeah, they have to have a lacunae when they're active. And this is the ruffled border, and this is the one, the surface will be facing the bone marrow. So these are the surfaces that not really active, but the other one, the ruffled border is. So inside the cell, you can see this enzyme called carbonic anhydrase 2, which generate the protons and the carbonate, which is this equation here. The proton will be transported into the resorption pit through what we call the hydrogen ATP pump. So we need to break down the organic matrix, the inorganic matrix, we need acid. I told you hydroxyapatite will break the minerals. So I told you before also, if you put a bone in an acid, it will actually dissolve your rubber. Why? Because it actually breaks all the hydroxyapatite inside. So we need this proton, which is increasing the acidity in this area, is going to come from the carbonic anhydrase breakdown. So we release the hydrogen through the hydrogen ATP proton pump. So we pump the proton here, become very acidic environment. That's why also we have this sealing, because otherwise the acid will spill outside, which is not good to the microenvironment, bone microenvironment. So the carbonate ions are exchanged for chloride on the other surface, which is towards the bone marrow at the non-resorptive surface. Because once you start losing all this positive charged ions, you need to have negative inside. So you get this chloride back, and also this chloride will be transformed inside through the chloride channel to be transformed inside the resorption pit. So we have both hydrogen and chloride. Chloride is not really needed for the resorption itself, but rather to neutralize the electric charge. Because if you keep pumping proton, which is positive in this resorptive pit, it will be after a while you can't pump anymore. You find the resistance because of the electric gradient. So you have to neutralize that. So we get some chloride in exchange for the carbonate here, and then we pump it through the CLC channel to put it in the resorption pit. So we have a neutral, not acidic neutrality, not about the pH neutrality, but rather electric neutrality. So this will break down all the hydroxyapatite. Once this is done, the calcium, of course, will be released and phosphate in this area, but then we need to break down the organic matrix of the bone, which is type 1 collagen. The degradation of this happens through enzymes called, one of them is called cathepsin K, and then the MMP, matrix metalloproteinase 9 is the major one, but matrix metalloproteinase is a huge family, there's like 30 something of them. But the MMP9 is the one you need to know, and cathepsin K, this will start breaking down the collagen. Later in the other lectures, I think the last one, I'm going to talk about why this is important and how they can be diagnostic to certain diseases. Okay, the last process called transcytosis. Now, everything, all these products of the breakdown of the bone existing in the resorptive pit. Now we have calcium, we have phosphate, we have also the breakdown collagen. This will be transferred because this area is sealed. We're not going to release anything to the environment. It has to be controlled. It goes through a process called transcytosis. Transcytosis, transport through the cell. So it goes picked up as vesicles and then released to the other side where so this is how the calcium is going to be released because of the breakdown of the hydroxyapatite, because of the effect of the PTH. Now it's going to go back to the circulation. So we'll get the calcium, this is the main thing, of course, and the phosphate also will go on other things, but the calcium is the main thing here that we need to figure. It goes back to the circulation and then goes bind until you feel all the calcium sensing receptors in the parathyroid, and the process will stop. Okay? So somebody summarized this with the bone resorption. It's already here, somebody can say it. Why everybody's shy? Or it's not clear. I mean, she did a great job. I need somebody else. This is simple. It's written. Just read the slide. Okay. Nobody's interested. Okay, so we said the regulation happened through two main organs. PTH will control the calcium through the PTH expression on the bone, but also we said that PTH receptor is expressed on the kidney. So this will affect how the calcium reabsorption in the ascending limb loop friendly. So if you have a problem at home with water, so okay, there's no drinking water. So what you do, first thing, you try to see if you have any stored in the back. Storage room and get some. This is what happened with the PTH. You get something from the bone. But in the same time, you eliminate waste. You don't know how much you have. So you tell your kids or family member, please nobody take a shower now. We'll just try to break anything that we don't be wasting anything. The same here with the PTH. PTH have a PTH receptor on the kidney, here in the thick ascending limb loop Henle. So here, this is a cell, a renal cell, and this is the blood. We have also PTH receptor and also calcium sensing receptor. PTH bind to the PTH receptor. What will do, it will actually reabsorb calcium because we're short of calcium. We cannot waste because we secrete calcium in the urine. So in this case, the PTH will go to the kidney and say, no waste anymore. Nobody take a shower. Please hold the water as much as you can because we need that back. So the PTH expressed in this ascending loop of Henle, and then when actually what it goes through this mechanism, this particular part of the kidney, it actually increase what we call the paracellular permeability. Calcium will go between the epithelial cells. We said before there's tight junctions between epithelial cells, but in certain conditions we can let them actually loose a little bit. So the calcium is not going to go through the cell, but rather in the places between the cells. So it's called the paracellular pathway. So the calcium will be absorbed through the paracellular pathway through the thick ascending limb fluid family. But also at the distal convoluted tubule, which a lot of calcium filtration happen, again the PTH will attach to the receptor, but in this case, through a channel called the TRPV5, it would allow the calcium to be back inside the cell, transcellular in this case. So we have paracellular and transcellular. So the PTH bind to the receptor and then increase the activity of the expression of this through cyclic AMP. Calcium will come back inside the cell from the urine and then will be binding to what we call cal binding, which is this calcium binding protein, and then we'll take it, transfer it back to the circulation through this calcium or sodium calcium exchanger, NCX1, and the calcium ATPase PMCE, which secrete calcium across the basolateral membrane. Through two mechanisms, the PTH will bind to the PTH receptor in the kidney, and then will reabsorb the calcium back. We're not going to go to waste. First, through the paracellular mechanism, they go in the cells in the thick ascending limb fluid of Henle, and the distal convoluted tubule is going to be transcellular through the TRPV5. PTH receptor, PTH bind to the receptor, will open this TRPV5 channel, calcium will come back from the urine inside the cell, will be transferred inside through those two mechanisms, the NCX1 and the PMCA4. So this summarizes the whole mechanism here. So what triggers all this is the changes in the ionized calcium. Low ionized calcium will be sensed by the calcium sensing receptor on the parathyroid gland, the chief cells. They will trigger two responses, one on the bone, one on the kidney. In the bone, will stimulate osteoclast to release the calcium from the stored bone through the rank ligand OPG, rank ligand OPG. They also work on the kidney to increase calcium reabsorption and decrease loss. So they increase the reabsorption through two mechanisms. One through paracellular, through the ascending limb fluid family, or through intracellular, through the ascending distal convoluted tubule, and this will be open at TRPV5, which allow the calcium goes back inside the circulation. Clear? Okay, good. So a couple of slides on bone diseases. We talked about osteoporosis before, which is, again, because we talked about the remodeling process. But normally we have the trabecular bone, which should be like this. It is a CT scan. If you look at if you have increase, could be because of the PTH increase and other problems, you end up, those are the thin trabeculae. So the resorption is going faster and there's not enough rebuild. So you end up with, we'll talk about toward the end. You tip up the balance. So the mechanism by which resorption happens surpass what we call the bone formation. And what we call this called high bone turnover. Bone is really breaking down faster than it is. These are measured. Most of the people that come with bone disease to you in any discipline, wherever you work, family physician, internal medicine, dermatologist, or orthopedic surgeon, 90% of the patient will come with this disease, osteoporosis. Very, very common, especially in female. It's imbalance between these two make it a problem. And I told you, because the trabecular bone exists mostly in the epiphysis of the long bones, but also in the vertebra, the fracture of the vertebra is much more common. It's very difficult. Although we have a lot of trabecular bone in the cortical area, in the epiphysis, in the diaphysis, in the long bone, but because we still have cortices, so it's still protected a little bit. But the vertebra, if you look at the vertebra histologically, the cortex is very, very thin. So they rely basically on the trabecular bone, and the remodeling happening really high in the trabecular bone normally. So you end up with a disease. It's a fracture vertebra, very painful. Over time, and it's difficult. I mean, surgically it's very tricky to fix this. But you don't want to go that far with these patients before you develop this. You can actually protect them somehow. The other thing that I need to mention is called bone metastasis. This is what I've been working in research in the last 30 years. So what you happen with the cancer migrate to a different site, metastasize, spread. And this is what kills the patient, by the way. Most of the patients with cancer, if they have primary tumor that doesn't metastasize, they live. If they have metastasis, usually they die. And they go to the bone. Bone is a little bit different because what they do, the mechanism with the remodeling changes. The osteoclast here, when you go to the bone, is a different story for the cancer. Even if they try to treat the cancer, it doesn't heal. Because what they do, they keep the mechanism of remodeling. Most of the cancer that you can see, they break down the bone here, they increase the osteolytic activity, increase osteoclast like crazy. So they start having active osteoclast and they break the bone. Break it like not the osteoporosis, no, they chew the whole thing. So of course they develop fracture and many, many things. So a lot of time that the drugs that they treat osteoporosis can also treat or control this to some extent. To the extent that some of the companies, they have a drug that I'm going to talk about, they give it two different names, the same drug, to give it to the cancer patient versus the patient with osteoporosis. Because some patients say, no, I'm not taking cancer drug. They look up things. So they just give it a different name, same thing. So it's funny how people perceive our cancer not taking, but it's the same mechanism. Because mechanism is the same. You increase osteoclastic activity regardless. It's just way more in the cancer versus the osteoporosis. You can also, in some of the cancer, you can develop osteoblastic bone metastasis. Prostate cancer, for example, increased bone formation. It's not good either because it's very random. So it's not like, if you have a table, you have to put the 4 legs in certain places. If I put 8 legs but on one side on, it's weak. So this happened also with this certain disease. The rest of that, this is what I was talking about. There's a very, we call it reclass in the market. This is anti-rank ligand. It looks like an OPG. You give the drug and occupy all this rank ligand. So they delay the resorption process. So this is in the market for a long time. This is the one they give it 2 different names for the cancer patient versus the osteoporosis patient. The other drugs, there's a group drug called bisphosphonate. This is actually the oldest drug. Basically, they bind to the bone and become toxic. Osteoclasts start chewing the bone, they die. Like you poison them like rats or something, and they don't resolve with the bone surface. So I'm not going to ask you about the drugs themselves, but you need to know how they work and how this is related to everything. Okay, this is a summary. So thank you.